Good evening to each and every one of you. I greet you in the name of the Lord that surpasses all human understanding. It is a pleasure to have you all in this house today. We continue to declare the blessings and the glory of God in and among us. Amen. Praise the name of the Lord. So we about to start. Please let us stand, and first let me say thank you for attending this symposium, this health symposium. And here with us this afternoon is Dr. RAELENE, Nurse Wilson, and Nurse Joseph. And any other colleague that may come with them, let's just give them a hand. Now, to our listening audience on the social media, good morning, good evening, good night. Depending on which part of the world that you'll be viewing this thereafter. So let me just open with a word of prayer. Father, we thank you for today. It's a good day. We give you praise, we give you honor, and we give you all the glory that belongs to you. Father, there are so many health issues that are plaguing the world, that is plaguing our land, that is plaguing homes. But I thank you, Heavenly Father, that you have risen up those that are in the health facilities to work with us. Because many a times we pray, and we thank you for every prayer warrior. But sometimes we don't have the right information. And I thank you, Heavenly Father, that today information will remove ignorance. And so, God, we bless Dr. RAELENE and the team. We bless the recipients, those that are in the house and those that are online. May this be beneficial for them, that we will take away that which we received. And so, God, we invite your presence in. And we honor you in this day, in Jesus Christ's almighty name. And let us just say, amen. Amen. Now, for the order of this symposium, Dr. RAELENE, she will possibly, you can have a seat, introduce the others, but we remain here in the main sanctuary. And for the other blood pressure testing and sugar testing, we move to that room, and of course it will be by order. Amen? Praise the name of the Lord. So let us welcome our Dr. RAELENE Allen. Come on, we can do better than that.
Good evening to everyone. So I'm very grateful to be here this evening to do a little presentation, and I have selected a few areas, health areas, health topics to discuss or to share with the audience, all right? So the first one that I'll begin with is dementia. All right. All right, so some of the objectives that I would touch on with regards to dementia: the burden of the disease, the criteria for its diagnosis, the cognitive domains affected in the disease, the progressive and irreversible nature of the disease, types of dementia, the changes that occur within the brain, and some of the differences between Alzheimer's dementia and vascular dementia. right. So this is a scenario that is very common. We have a 72-year-old gentleman, and his wife comes in with him, and she has a complaint. She complains of increasing forgetfulness. Of note, she has also noted that he has had problems keeping up with bills, and also he's forgetting where he puts things. He also forgets the names of his grandsons, and he has difficulty remembering words when he speaks. He recently began having difficulty dressing himself. Yesterday, he got lost on his way home from the supermarket, despite living in the area all his life. All right, so from that little scenario, that scenario sounds very common, yeah? All right, nice. Everybody know what dementia is, yeah? Everybody know what dementia is? Some people know what dementia is. So dementia, when we talk about dementia, we think about people who are very elderly, correct? Yeah? So we think about people who are over the age of 65 years of age, but there are some characteristic features that come with the disease. Now, from the little scenario that we had, I don't know if you all realize one thing. The first thing that happened in the guy, what was the first problem? Forgetfulness. And if you notice, it was increasing forgetfulness, all right? The other thing that we noticed, there was a little problem with language, right? He wasn't able to remember words, yeah? So that is one of the cognitive, if you notice, there must be significant, the criteria, significant cognitive decline. And when we talk about cognitive decline, the cognitive things that we refer to includes memory loss, it includes learning ability, it also includes language. We also have executive function, something that we call visuospatial cognition. That's a bigger word, but in the last part of the scenario, he went to the supermarket, and if you notice, it's a familiar place, and he lost his way, all right? So he wasn't able to remember the familiar places, all right? So that has to do with visuospatial cognition. We also have perceptual, motor, and social cognition. The next, you all could go to the next slide. So the next part that actually is affected, so we have, the first thing is that you have a decline in what? What's the first thing? Cognition. Cognition. The second area that is affected because cognition goes is that you can't function. So functional impairment. So if you have realized with dementia patients, as disease progresses, they need a caregiver. They need a caretaker. The reason being, they have lost that independence, all right? So they lost independence. See, the cognitive deficits that has occurred does not occur exclusively in the context of delirium. Delirium is something that happens like suddenly. So dementia is something that's progressive compared to delirium. All right, and sometimes you may have that conflict, or it might be very confusing, all right, particularly to the doctors, that is. The cognitive deficits are not explained by another mental illness. So that simply means that other mental problems can give you cognitive problems too, right? But dementia is not explained by those other things. So it means that when you see the patient, you must literally eliminate, or what we call rule out, something that is a mental problem. So some of the mental problems that could come with cognitive deficits would be major depressive disorder and schizophrenia. You all understand so far? We'll come to the question part. So this slide just highlights some of the types of dementia. We could go to the next slide. All right, so we have what we call, this is our big terminology in medicine, but it simply means causes. etiologies would be causes. I want you all to just note that we have things that are reversible and things that are irreversible. All right? So if we focus on the reversible things, we're not going to go through all of them. All right? But the two under what is called metabolic, two key things. When we see somebody who has dementia, we always want to look for things that we could reverse. We don't just want to say, you have dementia and that's it. It's irreversible. So we have reversible things. We have number one, which is called B12. B12 is one of the vitamins that we're supposed to have in our diet, and it's very, very important for many things, including cognitive function. So if a patient has very little of this by means of doing blood tests, that patient can present with some cognitive stuff. And the cognitive stuff we said would be learning, memory, language, visuospatial, anything within those cognitive domains. Another thing that is very common is problems with the thyroid. So the person may have very low levels of thyroid. So the key thing is that the takeaway point here, dementia, you have reversible things, right? Not everybody will have an irreversible cause of the problem, okay? The irreversible things, if you notice, under the secondary, so when we say primary, what we mean, we mean conditions that literally see here is, as the disease progresses, you notice that cognitive decline happens. Yeah, you all seen that? Right? You seen we start off with normal aging. Normal aging happens. You see the trend that should happen during aging. But when you have dementia, if you notice, there is this gradual decline. It's not like the normal, you forget a little thing. You know, sometimes As you get older, you probably forget something. You understand? But dementia is totally different. There is this progressive decline. And also with independence, if you notice a similar thing, as the disease progresses, all right, what you notice is that the level of independence would also gradually decline. You all getting that from the images there? You all getting it from the images? I ain't nobody. Right. So this is what we see in here. So the impact of dementia is so significant that it not only affects the cognitive aspects of the individual, but they cannot function for themselves after a while. Yeah? All right. All right. We could go to the next slide. This slide simply speaks about what we call prevalence. This is the amount of persons who have the disease, which is actually very significant. One of the things that's highlighted here is that as you get older, right, every 5 years over 65, there's a doubling, right? There's a doubling of the cognitive problem. We could go to the next slide. All right. The focus here, this is a focus by Pajo, which actually shows that in the Caribbean, as well as in the Americas, there's also a serious problem with dementia. So apart from it being global, we have a problem in Latin America and also the Caribbean. All right, so the global prevalence here, I'm seeing, this is in the Americas, 10 million people living with dementia. All right, we have some other figures there. That's a projection in 2030, 7.6 million projected. You could go to the next slide. All right, this again is basically Pajo recognizing that dementia is really a serious problem, is a public health concern. You could go to the next slide. All right, this slide is very busy, but what I will just highlight is that we have different types of dementia. And the three that are highlighted here, remember we spoke about those that are irreversible. All right, so we have the number one that we know about is Alzheimer's disease, and that's so prevalent. It tops all of the different types of dementias. And we see it accounts for 50% of all the different types of dementias. How does this occur? Some of the cases, you may have some sort of family, so it's passed on. It's what we call genetic, passed on in the family, but that's rare. And then you have the other cases that we call the sporadic cases. The other one that we have is the vascular. And remember, the vascular, as I said, you have strokes, you end up with this type of dementia. And this accounts for a smaller percentage, 5 to 10. And again, there isn't really any familial or genetic or hereditary pattern to it, but it's sporadic. All right, the next slide. This is another one. This is actually the last one. This is a special type. Again, people wouldn't know about this because you just wouldn't know. We would know about it, right? So this one is the Lewy body dementia. And this one accounts for about 10%. Again, the pattern is sporadic. All right? So we could go to the other slide. All right. So with every disease process that we see, everything, there's a risk. Something is happening that increases the chances of getting the particular disease. The same thing is with dementia. So everybody know by now that age, as you get older, we said over 65 years of age, that there is actually a doubling, all right, with every 5 years over 65, that chance of getting this cognitive problem
happens. So that's number one. Number two, we saw a family history, but we saw that is rare because most of the cases it just happens like that, which is called sporadic. Then we also said cardiovascular. So that, remember we touched on one of them being vascular with the blood vessels. So this is the link with that vascular. You must have things like this: high blood pressure. Not just high blood pressure that you're treating and it's well controlled, but uncontrolled over years. Diabetes, uncontrolled as well over years. Stroke, so a history of recurrent strokes. High cholesterol, and obviously obesity. Then we have some other things there. A lot of these things could be modified: obesity, high cholesterol, diabetes, high blood pressure. We have smoking, right? Alcohol use. They highlighted physical inactivity, hearing loss, head injury. So a few other things could actually, these are risk factors, but one of the key things is as you get older, over 65, the risk is going to increase. The next slide. All right. So this here is a little picture of the brain. And basically what this is showing is that dementia basically can affect every single part of the brain. This is what this is showing. So I guess you all probably don't know what is the frontal lobe or the parietal lobe. But these are lobes in the brain. So the brain has 4 lobes, and these are the frontal, which is in the front. So the brain, you have, it's cut down in the middle here, and you have one side and one side, right? So at the front, we have the frontal lobe. At the sides here, we have 2 lobes. They're basically like mirror images: parietal and temporal. The temporal is like hidden down here. And at the back here, the occipital. And we also have that little area that's mentioned, the hippocampus. All right? So throughout the disease process, especially with the Alzheimer's, every part of the brain becomes involved. Every part of the brain. Right? That is why the person eventually loses. They can't function because every lobe of the brain literally becomes affected by the disease. The next slide for me. All right. This slide here is an important one because this actually, this part of the brain, the structure, which is called the hippocampus, everything. Almost everything they forget. You understand? The first problem that the lady had, the scenario, the husband forgetting this, he very forgetful, he forgetting the names of the grandsons because memory. Hippocampus, memory. Memory loss. All right? The next slide. All right. So Alzheimer's dementia is progressive. All right? So it's not that we have two different categories of presentations of things. We have things that are acute and we have things that are chronic. All right? So dementia is something that's chronic because it takes years to develop. You don't just have somebody who come in, today they're forgetful, tomorrow, please God, it's like the worse than the day before. It's not like that. It's progressive. So you see them a month, 2 months later, something a little affected again. You see them, they lose something. You see them a year later, they get a little worse. So it is something progressive. All right? So this year gives us some sort of the manifestations. What do you look for? All right? We already said number one thing that goes in Alzheimer's dementia is memory. And one of the first losses, the first memory loss is what we call the anterograde, meaning that they can't form new memory. They can't form. So probably today they did something when you ask them, but you didn't do this yesterday? You can't remember this? No, they can't remember it. That is the anterograde. Any new memory, it's totally wiped away. All of the past stuff, it's preserved. So there's a preservation. However, as the disease progresses, all of the past things, past memories will be wiped away. All right? Y'all understanding? Yeah? Because of the progression of disease. Everything doesn't happen suddenly. It is not like that. It is a progressive disease. Right? As time goes on, so even in the early stages, you have the language that's affected as well, and the visuospatial. So the visuospatial, sometimes somebody may go to do something. Say they're accustomed going to the bank, and they're accustomed taking a route, all right? And for some reason, you find they're gone and they're taking hours. They can't come back. When you check, you gone out and you realize that, or somebody call you and tell you that, your family so-and-so. It's because they forget the route. You understand? They're accustomed taking that route every single year, every single day, and some gradually, it's not somehow, but gradually, they just forget. So they forget landmarks. They forget the grocery here. They forget this is the turn to make. They forget all those things, and that's visuospatial, and that happens very early. The ability to perform motor skills, so for example, cooking, tidying the self, all those things are lost. They can't even do things like go to the bank, and that shows how their independence totally lost, right? Again, as cognition goes, independence goes, all right? And later in the stage of the disease, other things go. They can't plan, they can't do certain things, and there's also what we call a psychiatric. These are our terms. But what happened is that some of them could have some depression, some of them could become agitated. I don't know if you all ever saw somebody with Alzheimer's agitated. You understand? They're real agitated, and you have to give them some medication, unfortunately, to keep them, to keep them calm. All right, good. So we have personality changes. So some of them may become aggressive as well. You understand? Right? So the personality changes can also accompany, all right, the disease process. Some of them may have psychosis, and you may think, they're schizophrenia or something. No, it's just a part of the whole disease process, all right? All right, so this slide here is just compares the normal brain and the brain that has Alzheimer's. So if we notice the normal, there's a little name there, neuron, which would be the cells that are in the brain. And then we have some little things that taking place there. If you notice that you have something outside of the neurons, I can't point, but I hope you're noticing it. There's something called amyloid plaques. You all seen it? Yeah, amyloid plaques, and then there's something also within the cell, in the Alzheimer's brain, a big term, but neuro meaning brain, fibrillary tangles. So just in short, you all don't need to know the names, but just in short, this is what is happening within Alzheimer's brain. So things, things depositing within the cell. They're not supposed to be there, but they're depositing within the cell. So plaques literally accumulating within the neuron in the brain that's supposed to help you to think and to learn and to remember and to recall, right? So you have these things in the cell and you have things literally outside of the cell. This is basically what the slide is showing. So this is what is happening, and as a result, the cognitive decline will happen because of these changes that occur within the brain. All right? So this is simply looking at the brain, all right? And I don't know if you all noticed some changes in the top brain, which is normal, and the bottom brain that is abnormal. All right? So the top brain looks nice and healthy, and it looks full. The bottom brain looks sick, and it looking sick. It looking as if like somebody eat out something, you know, eat out a part of the brain. Yeah, you understand? So you can imagine that. You can imagine an Alzheimer's person, part of the brain eat out, but that's not the word we'll use. Simply put, it shrinks. Because what happens anywhere in the body, when you literally dump in something inside a structure, inflammation will happen over time. Scar tissue would happen over time. Scar tissue shrinks. So this is what is going on in the brain. The brain, all these plaque and the neurofibrillary tangles happening outside of the cell, the brain gets damaged, inflamed, starts to shrink, right? We call it a terminology called atrophy, but simply put, it shrinks. And because, remember, we said the first part of the brain that is affected is the hippocampus goes shrink, right? And then the hippocampus is right near the temporal lobe goes shrink. And if the frontal lobe gets involved, the frontal lobe will shrink, all right? So somebody who has Alzheimer's, if it is you do a scan of the head, take a good look at it. If you compare probably when they were younger, without the Alzheimer's, less than 65, their brain will look nice and full. When you look at it now with Alzheimer's, a lot of it is shrunken brain. Yeah? All right, this is another picture, right, of a similar thing that's happening. Parts of the brain has shrunken. Yeah? You could go to the next one. All right, this is simply talking about vascular dementia. So remember we said vascular dementia, we have what? What going on in the brain? Strokes, right? So anytime you think about vascular, you think of a blood vessel, vascular, right? But you think of strokes. Okay? So a lot of information here, but what it is you look for. If you have a stroke, you know, sometimes somebody may not be able to walk, so you look for certain symptoms and signs, right? But you also have to do a scan of the brain. Remember we said that once you have dementia, you must do a scan of the brain, whether that is a CT scan or that is an MRI, right? Okay? Because that gives you information of strokes. Not only the person probably can't speak or express themselves, but do a scan of the head and you will get the information as well. All right? So this is basically telling us what the criteria you need. They need to have some signs and symptoms when you see them. They need to have a CT head or a MRI of the head that's showing some evidence of it. All right? And then when you put these signs and things together, there must be some evidence showing that, okay, they had a stroke and then they started having some sort of cognitive stuff going on after. All right? So this is basically what this is saying. So if you want to diagnose somebody who has vascular dementia, they must have some signs and symptoms, and you must have some imaging, or you must have a scan of the head, right, whether it is a CT scan or an MRI. Next slide. All right. This just depicts the circulation or the blood supply in the brain. It's very simplified, but it actually shows that some of the vessels that could be involved, you have big ones and you have small ones, all right? And it's actually believed that the small ones contribute to a lot of the disease process, the small ones, because A lot of what we call infarcts. That's a small word, but what happens in an infarct is that there's a blockage in the blood supply to the brain, and the brain tissue would die. All right, that's what an infarct is. An infarct is a stroke. All right, yeah, good. So you can have infarcts going on within the brain, or even these small bleeds that you probably didn't even see. Sometimes a lot of things that happening in the brain with regards to strokes, people have no clue about. Even the patient, they have no clue. But when you do a scan of the brain, you see all the clues, all of it. You see a little bleed here, they had a stroke there, something going on there, right? So it's all picked up in the brain. Those things we call silent because they don't know. All right, the next one. All right, so this shows some some patterns of the vascular dementia. Remember, we said vascular dementia, your blood vessel, which we call the arteries, strokes, right? So remember, with dementia, for example, the Alzheimer's, it's literally a progressive decline. If you notice, we have 3 different patterns here. One pattern, the upstairs one, the first one, it shows that it's like a stepwise decline. So you're normal on top, no dementia, then you get a nice little stroke, you get some memory loss, something affected, you get a next stroke. Memory loss, something affected, you get a next stroke. So this is what we call multi-infarct. So it's a stepwise decline in cognition. The next one, you're normal in terms of cognition, and you get a good infarct in a particular part of the brain, and then wrap, you just become like, you have dementia. All right? So one is stepwise because of multiple infarcts. The other one is a different pattern, right? The other one is a progressive decline. Progressive. This word subcortical is basically, again, the small blood vessels that you can't see. The top part of the brain is what we call the cortex. The area underneath is the subcortical area. But all there receive blood supply. Yeah? Okay, so that's it for dementia. So I will entertain questions. Anybody has questions on dementia? Or everybody understands dementia? I could give a quiz now. Oh, gosh. Everybody.
Hi, good afternoon, everyone. Good afternoon, Doc.
Good evening.
So you spoke about the neurofibrillary tangles and the amyloid plaques, right? So these are things that develop in the brain. And it suggests to me that it might be avoidable, right? So can you share with us how it can be avoided? What are some preventative measures for those of us who have not yet reached that stage?
Right. So, good. So, especially the one that you can actually avoid would be the vascular dementia. All right, because remember, you don't have any clue that you will get these deposits in your brain. All right, and doing a scan of the brain does not pick it up. These things are actually picked up on post-mortem. Yeah? All right? So the vascular dementia, though, because a lot of the things, the risk factors are modifiable, you can change your diet, you can lose weight, you can stop smoking, you can do many things that would decrease that vascular risk. All right? Good? So that is one of them. To me, that is the only one that you could actually prevent. You could use preventative measures so that that would not happen. The others, like the Lewy body, those things, again, the things are deposited within the brain, and you wouldn't know. Yeah? And yes, we have medication, but the medication is not going to reverse what is happening in the brain. The medication does not reverse. For the Alzheimer's dementia, for the Lewy body, it doesn't reverse at all. Right? And remember, we spoke about some of the things that give you cognitive stuff that you could reverse. Yeah? Like if it is you have the problem with the B12 deficiency, you could do a test and you could reverse that because you could give medication. All right? As well as the thyroid. If there are problems with the thyroid gland, it's underproducing, you could treat that and you could reverse that problem. But where you have deposits in the brain, not reversible. Yeah? So that's why it is important for people to be educated so that probably they could capture it early. You understand? You start to be forgetful. You understand? At least your relative will know. Your relative will realize that, okay, this person, their speech, they taking long to say a word, boy, a sentence, boy. You understand? And they capture things early. Yeah? Right? Yeah.
Good evening. Yeah, good evening. I'm sitting here and I realize it's quite a lot. Plenty things to remember. And plenty to learn as well. But as you speak about strokes,
Yes.
all right, and I have here vascular dementia, speaks of stroke, correct? Right?
Yes.
I'm thinking of my husband who had a stroke. And one of the things that the doctor explained to me is that after have taken the scan, they observed that he had a stroke before that, but he didn't even know. All right, but he only picked that up when he took the scan and he saw like where there was some part of the brain was bleeding. Is it
Right.
maybe an artery or
Yes.
something? All right. My question is, can these blood vessels that got damaged and caused the bleeding internally in the head, can it be healed?
If the blood vessels
The blood
can
vessels
be healed.
Can be healed.
Yeah, you can. The blood vessels can be healed, but you want to ask also if the damage done, if it
Or
could be reversed.
Okay, added that too as well.
Well, the thing is, if it is you have, so if it is you cut off the blood supply, for example, in the scan that would have been shown, right? And you have the stroke, right? Which could be a bleed or it could be the infarct, yeah? All right? The area of the brain would be injured, all right? But the thing is, if it is you have, for example, multiple, one thing is not going to affect you, but you're supposed to have multiple things, multiple infarcts, you understand? And also depending on the area of the brain that is involved, all right? So once it is multiple, for example, we saw the multiple infarcts that happened in the first one where there was that stepwise, all right? That you can't really reverse. You understand? The thing is, when we talk about reversal, meaning that there is preventative measures that you take, all right? So if it is, say, for example, you have a stroke now, and you were a big, heavy smoker, to prevent a stroke from happening again, you got to stop. All right? Good? Because you get the information that if it is you continue to do it, you may have multiple strokes and it could end up in dementia. So you stop after you know about the first stroke. Right? That's preventative, so that you won't develop there wouldn't be a progression of the problem.
Thank you. Thank you.
Good afternoon, everybody. I am working with a lady. I worked with her for 35 years. When I retired, I had to go back because she started to go to church and will drop other people home, but then she forgets where she is. Now, what her problem is this now, that she has dementia very bad, Alzheimer's. Sometimes she's very aggressive. So another thing, she cannot go off as she will like. She cannot we have her in Pampers. But I want to know, she sleeps a lot. Sometimes you have to go downstairs to check her 3-4 times, and she will see you and then cover up herself. Another time, she would eat, and then she wouldn't eat. But she has a way of looking at you. And I find it's very funny because they have children around, and she's quick to hit. So what can we do about that?
Right. So that's the behavioral part, isn't it?
Yes.
That's the behavioral component of the disease. And the part that you're talking about, it sounds as if this is a late stage of her dementia. All right. Now, the thing is, for aggressive behavior, you have to give medication because remember, there's a threat to other people.
Yeah.
All right. Good. So for aggressive behavior, we tend to give, we call them antipsychotics. All right, so we give that, and the one that is normally used in dementia for aggressive behavior or agitated behavior is Haldol, right? So it comes as a tablet form, and that is prescribed. The part where you said the person is up a lot, right?
No, she sleeps a lot.
Sleeping a lot because sometimes even when in dementia, you could reverse things, meaning like the pattern of sleep, wake, there could be a reversal. So a lot of things happen. So the behavioral changes, right? It doesn't say that will happen with all dementia people, but that is a component of the dementia as well. And the Haldol is the drug of choice.
Well, she's under medication. Another thing, she takes the children thing, and she wouldn't give it to you. She hide it. So I just have to play mother and say, okay, mama, come, go do this, come, go do that. So I start telling the children, all go on, don't let us see all of us.
Right.
Because 1 minute she's good, and next minute she's very agitated.
Right. Yeah, so again, that is behavior. That's changes, behavioral changes that accompanies the disease process. Yeah?
So what
Yeah.
can we do?
No, well, yeah, that's why I just said medication.
She is on medication.
No, but I just said Haldol.
Oh, pardon.
Yeah, that's what I said. Haldol. Haldol will help with the agitated behavior. Anybody who gets agitated, you have a schizophrenic or a manic person, get them a good dose of Haldol. They go subside. Yeah?
Thank you.
Good afternoon, everyone. My question is, does dementia and Alzheimer's go hand in hand, or is it the advance to dementia, Alzheimer's?
Right, so remember, dementia is a big, broad thing. Yes, an umbrella. Alzheimer's comes under that umbrella. Yeah? Alzheimer's. Remember, that was one of that's like 50% of people having that, you know. That is one of the irreversible causes. So it comes under the umbrella, right? Then the vascular comes under the umbrella. Then the Lewy body comes under the umbrella. That is why anybody who comes in with any form of cognitive decline, memory, language, learning, all those things affected, you have to do all of your tests before you can, so you're excluding this. It's not vascular. You do a scan of the brain. You do your thyroid test, it's not that. You do your HIV test, it's not that. You do your B12 test, it's not that. And then you could say, hey, okay, I exclude everything. Yes, likely it is Alzheimer's dementia. Yeah? All right?
Any more questions? Or everybody? All right. Yeah.
Yes. Very important question.
Okay.
For family members
Yes.
who have relatives with dementia, and it could be very frustrating.
Yes.
So how would you advise those family members
First
to be
of,
able to deal with?
sure. First of all, education. All right. The society lacks in education with regards to dementia. Obviously, it is totally. We have different groups available in Trinidad and Tobago. All right, that deals with dementia. How much do they reach out? I don't know. All right, but if you go online, there are different groups that specifically deal with dementia. I don't know if they have outreach that's available. We don't have any facilities like through the hospital. You know, if you go abroad, they have everything down pack. You know, so they have association for this, they have that. You come to the hospital, you have leaflets, you have everything, and right? Unfortunately, we don't. So for us, it is probably going on the net. That's how we do it. You're going on the net, but education is number one. You understand? Education is number one. Education is number one. But you need support. So it is very tiring, especially with the progression of the disease. You understand? Because sometimes you may be having a conversation or telling your relative something, and your relative adamant that it is not this, that is not this. I leave this here, but you didn't see this here, and your teeth nothing. You understand? And you have to deal with this every single day. And sometimes they're normal. They have a normal conversation. And then sometimes, you understand? So you have to develop a certain level of tolerance as well. However, I believe if it is you can't cope with the individual, your relative, you need help. That's the reality. So if it is you need help, you have to reach out for help. And to be quite honest, dementia is something where people have to have a real good understanding of how it affects the individual to be able to work and help the individual. Relatives need coping skills. It's a real multifaceted because people become stressed, burnt out. You understand? They need help. All right? So education, help, get different resources so that you would have the education, all right? And also people to, well, you know, like geriatric nurses or probably homes that would be able to offer help. Because remember, the independence of the individual is affected significantly. So you need help. You really need help. Right? So education and support from families. The whole family need to be educated. Or the key people who caring for the individual need to be educated. You know? And they need to have the resources available. So, you know, I could call this hotline. Well, we don't have it, but... Any other questions?
Doc, good afternoon. Now, I know that we have a listening audience and we were down for a little while.
Yes.
For that's it, could you just recap quickly
Sure.
What are the early stages or the early signs of dementia?
Sure. All right. So, good afternoon, everyone. All right. So, we have been chatting on dementia. And we have shown that dementia is really a serious health problem. And what we have shared so far is that you have umbrella. Dementia is a very broad term, and you have dementia that could be reversed as well as that can't be reversed. We have also shared that one of the biggest chunks in that umbrella is Alzheimer's disease. And we also saw that another little chunk is the vascular dementia. And we also saw that we have some others, all right? But we have seen that the cognition goes gradually because it's a progressive disease, and the level of independence of the individual gradually declines as well. Don't forget, it's not just dementia.
Good
evening, everyone. I was actually going to ask a question for dementia, but just quickly, I came in late. So whatever last bit I heard is what I wanted to find out is dementia. Now, there are certain diseases that are, bloodline related, so hereditary. Is this one of those diseases that is hereditary?
You really came in late.
I'm so sorry. But yeah, I did. I came
Yes.
late.
So dementia. So we have what we call the hereditary dementia has the Alzheimer's dementia in that umbrella. Some of them hereditary. But what will happen, the hereditary ones tend to occur, the onset will occur earlier than the 65. Anything that's hereditary, that's catch you early. All right? So those will occur earlier, all right, than the others. But that one has a hereditary component to it. But most of the dementia is sporadic. Yeah? So there's no hereditary component to it. Yeah? All right?
And just one more thing. Well, Mommy was mentioning something about B12, and I have been hearing about, B12 a
Yes.
lot. Is that, can you be B12 deficient, and how dangerous is that to your health?
Right. So, yes. So B12 is a super vitamin. All right. And it has an impact on multiple things in the body or multiple systems. So it could affect the way that your blood matures, the blood cells, that is. All right. So you could end up having a low blood count, which we call anemia. But you could also have the neuro, which is the neurology part, the nerve part, and psychiatric part to it. Psychiatric, right? So you could have cognitive stuff. The same like a dementia picture happening. And also with the neuro stuff, the B12 is important in what we call myelination. So all of the nerves in our body have a coating around it, which is called myelin, myelin. That's significant. What that does, it allows for the transmission of a nerve impulse. If you remove that myelin sheath, things go haywire. You can't walk because you remember the motor function, your sensation, you feel pins and needles, you understand? All right? So if it is your B12 deficient, you can have somebody could come in, oh gosh, they're weak, they can't stand up. You understand? They have lost strength, power. When you test them, no power in their legs. All right, good? They have pins and needles. So it affects the myelin sheath around the nerve. So you could have the neuro part of it. You could have the psychiatric part with the cognitive. You could affect your red blood cells. So you could have an anemia. There's a particular type of anemia that we call it. All right? So lots of things are affected with B12 deficiency. People like to give B12 shots, which is something that is very stupid, all right, because you have to have a deficiency to give a medication. So you have a deficiency of it, you do a blood test, and then now you can actually administer B12. All right, so you don't go to a doctor's office, hey, I'm feeling tired today. We have B12 shots. You want a B12 shot? That is not how we do it. You're deficient, you get. So a lot of, I don't know if you're all aware of this, but a lot of doctors, for whatever reason, you go to their office, IV fluids and B12. Hey, do I need B12? No, I don't need B12. Did you check my blood? No, but you get my B12, right? So we don't need that. You have to do a blood test. Or you probably have symptoms, and those symptoms carrying you down a way to explore, to see if they're really B12 deficient.
So then, would you advise...
We need to take that mic from you.
I'm sorry. So would you advise so that you can just to know that you do a test to see if you're deficient, and is it... Because, they have these supplements, and I think B12 is one of them.
Right, yes.
Would you advise people taking B12 supplements just like that, or you have to actually know that you're deficient before you take
the thing is, you need Bs. You need your B vitamins, yeah? You need your B vitamins, okay? So you're taking multivitamins which have B1, B2, B6, B12, right? Good. But you don't necessarily need to go, because I wouldn't just go and do a B12 test. You understand? I do a cognitive decline. What am I going to do that for? I have weakness in my legs. What am I going to do that for? You understand? Something needs to prompt you to do it. You understand? Yes. Right? Okay? It's just like, you wouldn't just go and do an HIV test, so. You understand? Who will do that? All right. So we could proceed with the other part. I doubt we would finish everything. Okay. All right. So we're going on to the second part. Again, we have some objectives. So everything comes with a little burden, right? So we have burden of diabetes. This part here is focusing on diabetes. We have the understanding of insulin and how it works. Forget those big words. Understanding the concept of insulin resistance. Insulin resistance, and as a precursor to type 2 diabetes, the health impacts of insulin resistance, some of the symptoms, risk factors, and diagnosis of diabetes, and complications of the disease. Oh, that's a mouthful. Okay. All right. So, the burden of diabetes. Only think it have a big burden or not? Ooh, it's burden. Yes. So, it's a big burden. So, we have, again, we deal with what we call prevalence. Prevalence is the number of people with the disease, all right? Compared to what we call incidence, the number of new cases. So we have some years, and this is some statistics by the International Diabetes Federation, looking at both type 1 and type 2 diabetes, 2009, and we're going down the road to 2019. You'll notice a trend. Things get better or worse? It gets worse, and it's in the millions, you know. So things get worse, and then we have some projections. 2030, we think it will be better or worse? Worse. And then in 2045, however, they do projections, but 700 million people would have this disease. That sounds like sweetness, right? So we have all the reasons. They're saying that people too big. All right, the obesity issue. And obviously, we have lots of young adults now with type 2 diabetes, all right? Rapid increase in urbanization. Everywhere you go, you have a McDonald's and a this and a that and a, right? Okay, the next slide. All right, so type 2 diabetes ranks number 1. Like Alzheimer's ranked number 1, type 2 diabetes, he ranks number 1. All right, 90 to 95% of all diabetics are type 2 diabetics, compared to a very small percentage, which would be type 1. We have other types of diabetes, by the way. All right, the next slide. All right, so risk factors again. So there are stages. So one doesn't just become a diabetic tomorrow, please God. Tomorrow, please God, you're a diabetic. There's a progression. And we have some risk factors. So if one is overweight or obese, we normally do that by calculating the BMI of the individual, which is the body mass index of the individual. We have family history, which, you know, plays a role with almost everything, but this is important as you get older. We also have high blood pressure, which is hypertension. The other words there, triglycerides is a type of fat, okay? HDLC is also a type of cholesterol. Diet and lifestyle factors. We also have gestational is during pregnancy. So some persons may have some problems in pregnancy where the sugar's high. Afterwards, they have to be followed up to make sure that they don't become a diabetic. Then we have another condition called polycystic ovaries that occurs in females, and also some high-risk ethnicities, all right, where you have a prevalence, a very high prevalence, the African American, the Hispanic or the Latino, the Native American Indian. Yeah, so these are the risk factors that we have for developing pre- and diabetes and type 2 diabetes. Our focus would be on type 2 diabetes this evening. So we could go to the next slide. This slide is just on diet and diabetes. All right? All right. So some of the symptoms, I'm sure we all know symptoms related to diabetes. Yeah? Anybody want to say one? Sorry? Right. So you're going in the toilet to pass urine a lot. Okay? Anybody else know any others? I guess you're looking on the screen. Any others there? You always feeling thirsty. And it's not because the weather is hot, but it's because you have a lot of sugar in the bloodstream. Then we have some unexplained weight loss. Some people could always be feeling hungry too. All right? So the key things really is you're peeing plenty, you're eating too much, and you're real thirsty. Yeah? All right, the next slide. All right, so just to give you all a little understanding of what happens. So you all know about insulin, right? Yeah. So everybody shouldn't have heard about insulin, and you hear about insulin probably because you have a relative who taking insulin, okay? Or somebody you know taking insulin. But you know that insulin is a product in the body. Yeah? Right. And the only reason why you give it is because probably you don't have it in your body. Good? All right. So insulin is very important. So anytime you have a meal, and not just any meal, it's a meal, probably a carbohydrate meal. Carbohydrate meal. You drink some juice. You had probably a McDonald's, right? You had a soft drink, for example. Good? The small baby components to that is your glucose, all right? So once you have that meal and everything is well digested and you have your blood sugar being reabsorbed, what comes out first, the first responder is insulin, right? Right? Good. So insulin responds. And when insulin responds, it's a hormone. So it will bind onto certain tissues. Your muscle, your fat tissue that we call adipose tissue, and also your liver, right? So three key things: muscle, fat, and liver. And when it binds, any hormone that binds, it literally, a lot of changes happen. I'm making it very simple, but a lot of changes happen. And then channels for the glucose to enter the cell open up, right? Good? So insulin has to bind to receptors, turn on some stuff, a lot of enzyme thing going on in the cell, because remember, everything is at a cell level, right? You can't see it, okay? And then the channels open up and glucose come inside. Because glucose needs to come into the cell. Glucose is a form of energy, so it needs to come into the cell. Good? When glucose comes into the cell, we need storage, yeah? So glucose has to be stored, but it's not stored in the form of glucose. Again, you have a lot of enzymes. That's what we call metabolism. So it's metabolized into a bigger product called glycogen. So that's stored in muscle. Good? It's stored in the liver, right? So let's picture it. I have eaten a McDonald's. I have drunk some juice. A little while after, insulin comes out, binds onto my muscle and onto my liver, opens up these channels so that glucose could come in. When glucose comes in, it has to be stored because it have to be used at another point in time. It forms something called glycogen. In my fat tissue, what forms is fat. Yeah? Good? In my fat tissue, the glucose enters, and there's a conversion now to fats, right? To lipids. You all get that so far, right? Okay, let's go to the other slide. So that is the normal scenario, right? So let's see what happens here. So this is what I was explaining here. If you see insulin and it binds onto the receptor, you all seen that? And then we have the glucose on the outside, those little white things there. And if you notice, insulin unlocks the glucose channel, and you all seen the little glucose coming into the cell? You all seen that second one? Right. So that is the concept, very simplified concept there. Super simple, but not simple at all. All right, the next slide. All right, so here's what's going to happen now. To become a diabetic, there's this word here that's called resistance. Insulin resistance. Okay? So here's what's going to happen. So that nice process that we explained there does not happen because the tissues no longer respond to the insulin. Right? So the liver, the fat tissue, and the next one is what? Muscle. All you recall bad boy. All you have Alzheimer's. Oh, God. Oh, my way. Yeah, boy. do this sweet one first. Oh, my. Okay. So, we have the tissues. They don't respond to the insulin. Remember, insulin unlocking the channel for glucose to come in. But with resistance now, the insulin, the tissues not responding to this unlocking mechanism of the insulin. So if you all look at, there are three graphs up there. A and B, A and there's one under B. So healthy, then insulin resistance and type 2 diabetes. You all seen those three little graphs, right? So A, the healthy person, you're seeing two curves, one glucose and one insulin. So this is what happens. Remember the normal that I told you. So glucose comes and insulin comes right after, right? Good. If you notice the one below with the resistance, which one is on top? Like real high on top. Insulin. And type 2 diabetes, the graph there. Which one is on top? Glucose. Okay. So who could explain to me why? Nobody. Okay, so let me tell you. Let me tell you all why this is happening. So everything in the body, remember we have what we call homeostasis. So glucose is never supposed to be high. Never. Unless probably, you have reabsorption, but the glucose is supposed to enter the cells. So what happens is that when you have insulin resistance, where the tissues no longer responding to insulin, the pancreas, you all ever heard about the pancreas? Right. That is the organ, some cells there, that secrete insulin, right? Good? So the pancreas is going to compensate. And what do you think it's going to do in its compensation? Yeah, it's going to overproduce because it's saying, oh gosh, but what going on here? It's so much sweet thing around. We need to produce. You understand? So that's what's happening there. So the second one, insulin resistant, is what's happening. The compensation is we're going to produce lots of insulin. Yeah? So that's what's happening. That is a bad thing. Overall, that high insulin state is bad for the body. You will see why. It is super bad. And then eventually, if it is you just working me on, what's going to happen with me? I would break down. And that's what happening to the cells eventually. The number, after compensation, beta cell dysfunction. Those are the cells that secrete the insulin. It's not functioning much. Again, it overworked. And that is why people who have type 2 diabetes, if you notice, when it's uncontrolled, they start off with tablets and then what they need to get after? Insulin. Why? I just tell all you why. Beta cell dysfunction. Those cells produce and produce and produce and produce until they get so weak, they get little bit. You understand? So the last thing is what we will end up with. Where insulin, because the beta cell now working good, very, very little insulin compared to very, very high sugar in the body. You all understand? All right. As beta cell dysfunction happens, that is when now you start to get the person having pre-diabetes and diabetes. So if you notice, this is something progressive as well. But things could be reversed. It could be reversed. Yeah? Next slide. All right. So this is what, these are the organs that involve in insulin resistance. And a lot of things happen when you have insulin resistance. the body, the whole metabolism really goes chaotic, all right? And we have a lot of fat being broken down into fatty acids, and the tissue that's supposed to hold or store fat is the adipose tissue, all right? But some goes to the liver, and the liver, all you ever hear about a fatty liver? Yeah? Fat not supposed to be in the liver. But with insulin resistance, it ends up into a fatty liver. So fat goes in the liver, and when fat goes in the liver and it stays there, the liver, all you ever hear about cirrhosis? Right, it's progressive. You understand? So this whole concept of insulin resistance is very detrimental to many organs in the body. All right? Good. We could go to the next slide. All right. So this just again shows the progression of insulin resistance. So as we highlighted already, you have high, the compensation is high insulin. The next thing that happens, the beta cells don't work, so less insulin. And then you end up with the pre-diabetes and the type 2 diabetes. Yeah? All right. So this, how do we diagnose? So I think we spoke about, we did speak about the risk factors already. So we have pre-diabetes and diabetes. So pre-diabetes is not diabetes, all right? And it would not be managed the same way. So pre-diabetes, you know, everything we have values for, yeah? So you go to the doctor, and the doctor says, the doctor tells you, I want you to come tomorrow, please God, and we're going to do a blood test before you eat anything. What we call that one? The fasting. So they do the fasting, and the value is 120. Are you a diabetic or a pre-diabetic? Pre-diabetic. Then they say, let us do another test. After your fast, I will give you a sweet drink, which is the second test, the glucose tolerance test. I'm going to give you a sweet drink. And 2 hours after, so they mix some sugar in some water, they give it to you. 2 hours after, we're going to do a test. They do the blood test, the result comes up. It's 198. What are you? Pre-diabetic, right? So you're not a diabetic. So you're happy. You're very happy because you ain't cross, right? But you still need help, eh? Oh my. So then they do the test, the fasting test, and the fasting test is 200. What are you? You're diabetic. You're confused. You're diabetic because it's over the 125. Actually, it's supposed to be over 126, right? And then they do a next test, the same glucose tolerance, and it is 300. What are you? You're You're dying. Oh gosh, yeah, you are diabetic. All right. So these are some values. These are real values, though. These are the values to diagnose whether you are pre or you are a diabetic patient or person. Yeah. Yeah. The next slide. Okay. So remember, I mentioned that there are lots of really, really bad outcomes to insulin resistance. Insulin resistance drives all of these things, all right? So the arrows that going there, insulin resistance, we said is the precursor to type 2 diabetes, right? There's a condition, the polycystic ovarian syndrome, that drives that as well, right? Then you have the atherosclerosis, which is all of your plaque, fatty stuff within the blood vessel. Insulin resistance drives that. The hypertension, it drives that as well. Dyslipidemia is where cholesterol values, some of them high, right? Insulin resistance, you see how much things insulin resistance does? Yeah? So it's not just type 2 diabetes, you understand? But you could actually have all of those things happening, right? With insulin resistance. The next slide. Okay, some of these things just mentioned there, right? The fatty liver, the central obesity. You all know what central obesity is? That's obesity that you have, like, so in this area here, under the organs, the fat that accumulates centrally. Yeah? Right? So not on the hips and thing, central here. Right? Central. That's not a good fat. All right? Then, okay. So we also have hypertension. Hypertension. We don't have a south obesity. Metabolic syndrome. Okay. Some other big things there. Acne. You know. Hirsutism. That's where females have a male distribution of hair. So they may have it on their hair. Right? Here. They have beard and mustache and thing. All right. The first one there, the acanthosis nigricans. Some people with, well, y'all won't be looking down at people's neck, but right here, they tend to have, it looks very dark, like super, super dark. All right. And that is what we call acanthosis nigricans. And if you see somebody with that, it can mean that they have insulin resistance, and you test to see if they are a diabetic. Yeah? The next slide. Okay, so this year, remember we talk about the central obesity, right? So if you notice the visceral fat is what they're talking about. That's the fat that accumulates around all the organs, that visceral fat. It is not the same as the subcutaneous. The subcutaneous, under the skin, is not the same fat. All right? So the fat that we pinch in here is subcutaneous. That fat that is deeper down there around the organs is what we call the visceral fat, and that is not a good fat. All right? That fat is a bad fat. So people who like fat, right? Visceral fat is not a good fat at all. The next slide. Okay. Oh, all right. So this slide I think is a little bit incomplete, but this has to do with reversal of insulin resistance, and it can be reversed, all right, by diet, by lifestyle changes, by exercise, right? Strength training exercises, right? If you do like your HIIT training and thing, it can start to reverse insulin resistance, because a lot of the insulin resistance starts off at the level of the muscles, right? So it can be reversed. So you may find somebody who probably was obese, and then they started to do a lot of strength training, they going in the gym all the time, and then they lose a lot of weight. They probably was pre-diabetic, and then check their sugar. They're no longer pre-diabetic, right? Because insulin resistance has been reversed. The next slide. All right, so these other slides focus on the complications of type 2 diabetes, of diabetes in general, and a lot of them we are very familiar with, you know, the ones that affect large vessels. So it affects both large and small. These are chronic things, and then we could have the acute things that happen just like suddenly, all right? The acute things and chronic, we see patients with. The chronic things, you may see them in the clinic setting. The acute, they come through the accident and emergency. So the chronic ones, the large vessels, your strokes, because those are big vessels, what we call the heart attack, or the coronary artery disease and heart attack. The peripheral artery disease, those are persons who you may see them with a gangrenous foot, because they have decreased blood supply. That's peripheral artery disease, yeah? And then you have small vessels. So we see most of the organs affected by diabetes. The kidneys, so the nephropathy is kidney disease, right? The neuropathy would be the nerves. The retinopathy would be the retina of the eyes and the diabetic foot. All right? Okay, so these are just some pictures. So we tend to look into people's eyes, you know, to see some of the changes that taken place. And we have lots of changes that take place with diabetes where treatment is actually needed. So, I mean, if you look at, for example, this one on this side here, where you have non-proliferative diabetic retinopathy, right? Some real big words that you just have to learn. Non-proliferative diabetic retinopathy. So what happens is that the vessels, they become diseased, and because they become weak, some of them have what we call aneurysms, which are weak areas in the vessels. They will bleed. So when you look into the eye with a special instrument, you see bleeding. You may see other things happening there, hard x-rays. That's all what we will see. You all wouldn't have a clue, right? But that's what we will see. And then for the proliferative, what happens is there's a proliferation of the blood vessels. So again, when you look in the eye, you will see lots of blood vessels, all right, in the eye. Yeah? So everything, so I don't know if you're all noticing on this side, you're seeing some bleeding. Like in the lower part there, you're seeing in the second one on the lower, a big blob of blood. All right, so that's hemorrhage there. They said that is vitreous hemorrhage. Don't worry about the words. The key thing is that you have lots of changes in the eye, which includes bleeding, which includes a proliferation of blood vessels. That's in the latter part of the thing, which obviously will cause the person not to be able to see properly. All right, yeah? Some big words. Again, this on the second row to your right-hand side, right, we have that PDR is the proliferative diabetic retinopathy and neovascularization, which simply means new blood vessel. So you see how much blood vessels? You see all the vessels there? You all seen it? Yeah. Yeah. So lots of blood vessels. So all of these are changes that happen. Somebody have a pointer? Lots of changes that happen with diabetic disease of the eye. Right? The next one. All right. So this is the foot. We are very familiar with the changes that happen in the foot. All right. So we have some, what this one showing here? An ulcer under the foot. And if you look at the other one, right, we see in how the foot has become deformed. All right, so you can have deformities that occur in the foot as well. And a lot of these things, so the ulcers and deformity is because the blood vessels and nerves affected. Remember, with diabetes, a lot of these nerves are what we call sensory nerves, so your sensation is lost over time. All right, so the arch and the sole of the foot, that architecture is lost, so you can end up with deformities of the foot. The next slide. All right, so this is a common presentation that you will see. If you notice, the top of the foot looks very dark in color. You all noticing that? All right, so this is obviously an unhealthy foot. So you see a foot like that. You look down at your foot. Oh my gosh! This wasn't like that yesterday. No. Over time, nah, boy. And you stay home with that foot. You stay home with that foot. You stay home with that foot. That foot, you need to go to the doctor. All right? So that is because of peripheral vascular disease. So if you notice the plaque that's causing the blood vessel to get narrow, you notice that, right? The regular artery, nice and patent. Blood flow is fantastic. Watch out the other one. You think blood is getting to that toe? Nah. So that's why the toe getting like that, right? So we call it ischemia. We use lots of nice terms. Ischemia. So when we're talking to people, it's like, oh, you are so lost. Ischemia. All right? So this foot is an ischemic foot. All right? Yeah? All right? So we could go to the next slide. Watch out that foot. Tell me, would you stay home with a foot like that? No, but you know people do stay home with feet like that. Why you think they stayed home? I don't want to go to the doctor because they got cut. No, but this foot is a diseased foot. And the blackness is because of, what's the nice word I tell all you? Ischemia. Come on, guys. Right, so anyhow, decreased blood supply. That's it, full stop. Right? The tissue dying, the tissue dead. So that needs to be amputated. All right, and this just looks at the nerve-related changes that can happen. So lots of injury, damage to the nerves, all right, that could happen with diabetic foot. So the ones that we highlighted in terms of common complications, the diabetic foot, the diabetic, the eyes, and the nerves, right? Different things can happen with the nerves. It's so varied. Yeah? The next slide. All right, so that's it for the diabetes. So again, I would entertain questions. Any questions? Everybody understand diabetes perfectly? Yeah, look at getting the mic.
Monday going.
Yes.
They said that the pressure was okay, and they wanted to have diabetes. My sugar was 191, not now, but some months ago. And the doctor told me I was diabetic.
Right, but what test was that? Was that a fasting
A fasting
test?
blood test, yeah?
All right, so let the congregation answer that question. Congregation, after the information that was shared, is she a diabetic or not? That was a fasting test.
Not. 191. Mine? 190 was not pre-diabetic, I wasn't diabetic.
It was 119 or 190?
191.
191, right. She was pre.
When I took it home, it was not 191.
All right, okay. Okay, we got that. Yeah, yeah. But I mean, if it is you were fasting, right? Right, so you're fasting. But so remember the values that we had for the pre-diabetes, it was 100 to 125. So what I would suggest to you is either the machine from the people not working or your machine ain't working. No, for the blood sugar. Right. Okay. Relax, 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 relax. Relax. Oh gosh. Yes?
The nerve, right?
Yeah.
What did I take for the nerve? Because the doctor really put me on Nutribin port.
Right. So you are having what? You're
Some-
having symptoms, pins and needles? What
Yeah,
you
in the
having?
foot.
Burning and thing?
Yeah.
Okay. All right. Cool. So for nerve-related pain, you don't use the same medication for other pains. Yeah? All right. You know, Panadol is not going to work. Yeah? Diclofenac, you know, everybody like a little cataflam and thing. That's not right because this is nerve pain. So nerve pain, you need medication or pain medication specific for nerves, right? So we have a variety of them, right? We have something called amitriptyline. Amitriptyline, you ever hear about that? All right, nice. So amitriptyline is one. We also have things like gabapentin. That's for a nerve. Pregabalin, Lyrica. Those things are for nerve-related pain. So you got to go to your doctor again. Say, Doc, what do you have for nerve pain? Right, so, well, okay, it helps, but the nice ones, Lyrica, yeah, Lyrica, amitriptyline. The thing was with these,
they tend to take it more so in the night because there's a drowsy component to it. All right? So you just have to keep that in mind. Yeah? All right? You're welcome. Whoosh. All you digest that good, boy. That diabetes, all you good. All you good.
The last diagram we saw there with the dark toes, right?
Yes, yes.
I'm asking if that could happen to your fingers as well.
Oh, very good question. Very good question. Super duper question. In the context of diabetes, nope. Nope. Because peripheral artery disease normally involves the legs, the legs, right? But you can have ischemia involving the hands and things. But that tends to happen in other diseases. But they would not get like that. What will happen is that you'll have discolorations that happening, but because there's decreased blood supply. Yeah, but not in diabetes. Yeah? Yeah? So this year is just feet. That's why diabetics always have to check their feet. You check under your foot. I have an ulcer. Oh gosh, it's infected. Oh my gosh, I need to go to the doctor. You understand? Then any kind of injury, you have to check in between the toes. Check the toenail. You understand? Check it good. Check and see what's going on. Because it's very easy for ulcer to come and you don't know because your pain sensation is lost. Right? It's you washing your foot all the time. You know, sometimes people just wash their foot and they don't check under their foot. They wash their toe and then checking under their toes. Or between their toes. So you check it. If you see another, check to see if you're getting a discoloration. Right? Check. You have to do checks. Sorry, say that again? Right. The ulcers, your sister, yes? No, but that person walks or not? Okay. I mean, she had an abscess before or something? Right. Right. So, I mean, with diabetics as well, when it is uncontrolled, remember the environment is actually conducive to infections. So you could have multiple infections and you could have abscesses as well. Yeah? So you could have abscesses as well. Yeah? Right?
That's nice. I want to know the difference between, I hear them talk about diabetes in the gangrene. It have wet. What's the difference between the wet gangrene and the dry one?
Okay, all right, nice. Thanks for the question. All right, so one looks wet and one looks dry. Oh, God, seriously, one looks wet and one looks dry. But the thing is, the dry one, you can leave it. Meaning that the surgeon will come, but the surgeon won't treat. Right? When it becomes wet, it means it becomes infected. Right? That is a problem because remember, if you get an infection anywhere, remember that is dead tissue. Dead tissue becoming infected. You know what's going to happen? You're going to become, there's a terminology that we use, septic. You're going to die. Chances are you go home, bye-bye. We're not seeing you anymore, right? You're gonna die. So the wet one is an infected one, yeah, and it needs to be attended to surgically, yeah. Right.
I had a brother who lost 2 of his feet.
Yes.
Because he had
the wet one.
Yes.
Yes. And also, you see the response by people. I don't know how, I mean, your foot to me is an important part of your body, right? So you see your foot looking a little black. You don't say, but that's dirt. you need to go to the, no, you got to respond. You got to respond very quickly. Something is wrong. Yeah? The word is ischemia. That's the word. You have a lack of or reduced blood supply because you have what? Oh, you saw the plaque? Yeah, so the plaque literally blocking the flow of blood. You understand? Blood want to go in, but limited blood. So the tissue dying. You see how blood nice? The tissue need a good blood supply. The blood have oxygen and nutrients, but the tissue not getting it. So gradually it dying. And how it is shown, looks black. You understand? That's the evidence of the dead tissue. We call it necrotic tissue. You like that word? Necrotic tissue.
My question, Doc, is,
Yes.
so I know that a lot of the information went towards type 2 diabetes, etc. But
Yes.
what is the difference between type 1
And type 2. All right. Okay. So type 1, what happens? Remember we spoke about the pancreas. So persons are actually born with type 1. Type 1. Okay? So what actually happens is that, I don't know if you all ever heard about autoimmune diseases. All right. So that's a type of disease whereby your body produces antibodies, but they destroy your own tissue. All right. So type 1 is that. You have these antibodies that specifically going to destroy the pancreas. All right. So once its target is the pancreas, you would no longer have those beta cells. Yeah, those same beta cells. So that is why those persons very early, they will have to be on insulin because beta cells have been destroyed by the antibodies against the pancreas. So that's the difference. So one happens very early and it's autoimmune because autoantibodies destroy the beta cells. Type 2, this is something, yes, you have a genetic predisposition most times, but this one is something that is progressive, right? Yeah? You wouldn't be like 12 years and you have type 2 diabetes. I mean, I'm not saying that it can't happen, because a lot of young people now have type 2, but there's a total difference. One is autoimmune. Type 2 is not autoimmune. Type 2 has to do with the insulin resistance. You still have a functional pancreas, but over time, you can lose that function. Yeah? All right? No, and that's it for the questions. Is now 7:05. At what time? Oh, that's the plan. Okay, no problem.
Yes, this question is actually from upstairs. Does a blood sugar level in the pre-diabetic range necessarily mean
Yes.
that you are pre-diabetic, or could it just be an anomaly?
Yes. Okay. Oh, all right. So this person is fasting. This is a fasting sample again.
I don't know, you might have asked the person.
Okay. So, all right, sure. So, all right. The thing is, if it is you are fasting, and you go by, you take the sample, the fasting sample, meaning you have not eaten for at least 8 to 12 hours, all right? And you get this reading, unless there is a problem, probably with calibration of the machine, that you run the test on. There's some problem with regards to that. Once it is in that pre-diabetic range of the 100 to 125, you are a pre-diabetic. Yeah, less than 100, you are not a diabetic. Yeah? Right? Any other questions? Or everybody? Good. Sorry? Plenty to observe. It's too much or what? Always too much? So saying it's frightening.
thinking, I'm thinking of those of us who probably on a Friday night we don't cook, right? So we go out by the corner
Right.
and buy wings and fries, or we buy foot long, or we buy fast food, right? All right. How much of a yes, I'm going.
How much?
How much of a contributor can that be to diabetes?
Or okay, you asking me a hard question. All right, so remember, everything is very cumulative. Everything is cumulative, right? And remember, this disease process happens, especially the type 2, let's be clear. It's something that happens over time, all right? And it would be not just eating a fast food, probably one Friday every month, yeah? It would be you doing this over and over. So probably your work day, you don't cook. You have to go and buy some Chinese food. Every single day you're doing that. Every night you're eating something that loaded with fat or something like that. So it's cumulative. It's happening over time. And that's why one good thing to do is to do blood tests ever so often. You understand? So you have your doctor that you're going by, and you're doing certain blood tests. And remember, you're looking at risk factors too. So if you know your father, your mother is a diabetic, your granny is diabetic, first-degree relatives, you know, they have the particular condition. You do your checks, right? So you will do your fasting blood sugar, yeah? You will check it. You will check your cholesterol and thing. You understand? So you're doing your own checks to see what it is, yeah? And if it is high, you know, you need to cut down on certain things. So everything is very cumulative. All right. So everybody is okay.
One more for the night. One more.
Yes, no.
Good night. Question.
Yes, no.
Diabetes. You have diabetes and you get cut. I know that normally doesn't result good. What happens there?
When you
what
are a
happens?
diabetic
Yes.
and you have a wound.
Yes.
Okay, sure. What do you think? You tell me.
I know it doesn't go well, so I want to understand.
All right. So, I mean, remember there's the risk of infection. Any person who gets a wound, and it could become infected, right? But with the type 2 diabetics, there is they are prone to having infections. Prone. So whether it is a urinary tract all over, urinary tract infection, whether it is a pneumonia, whether it is an infected ulcer, whether it is what we call a cellulitis infection of the skin, they are prone to having infections. And that just goes along with the poorly controlled diabetes because your blood sugar is high. And then what also happens is that the immune cells, they become dysfunctional. The immune cells, the cells that supposed to fight an infection, become dysfunctional. So you can imagine that they're dysfunctional and they're supposed to be doing a particular job when you have an infection, so they cannot work effectively. So that is why, one reason why diabetics are prone to getting infections. Yeah? Right? So if you have a wound, to answer your question, right, that needs to be addressed. You need to pay attention because the likelihood is that it will become infected, you will get an abscess, you will become very sick, you will go to the hospital, you might end up in ICU. I'm telling you a serious thing, right? Because of a little wound that you did not address and you are diabetic. Yeah? Right? Okay. All right. So we could go on to the other one. Oh, gosh. All right. Okay. So we will chat here a little bit about hypertension. Everybody know what hypertension is? Yeah? Anything that is hyper is a little too much, above the normal. And anything that is hypo is a little too much, right? So this is the blood pressure being a little too high. All right? So hypertension there's a problem with that, a cardiovascular risk. All right, I will explain that. That's just our terminology. How to diagnose it, what are the target blood pressures, and the complications. All right, so I hope you all can see this. So so this basically how we diagnose hypertension. And hypertension, if you go to the doctor today and the doctor checks your blood pressure and it is high, that's hypertension. Hypertension or no hypertension? Yeah, that's hypertension. Well, it's high, the blood pressure high, but it's not necessarily hypertension. So that's important, right? So some people might go to the doctor and the first visit, the blood pressure high. And what the doctor tell you? You need medication. What you gonna tell them? Nonsense. Okay, so, oh gosh, oh my, no. Oh, no, don't tell them that. Don't tell them that. Say, doctor. No. Sorry. I have to disagree with you on that one. All right. So we need more than one reading, okay? Sometimes they diagnose hypertension in the clinic setting or in clinic or out of the clinic setting, right? So what it is you need to confirm the diagnosis in A, you need at least 2 to 3 office visits where you check the blood pressure, 1 to 4 week intervals, because we know blood pressure fluctuates and it's so variable. You come and you probably had a hard day at work. You come and you sit down and the doctor or the nurse want to check your blood pressure one time. Serious? No, it's not making sense. It must be high. And then they say, girl, you are hypertension. Say, doctor, madness. So the next thing, single visit to the office or clinic with a blood pressure that looking real high though, boy. You see that number? More than 180 over 110. But here the next part, evidence of cardiovascular disease. You see that next part? So your blood pressure super duper high and you have evidence of cardiovascular disease. So you could actually use one reading, right? Good with that evidence, right? But normally we do 2 to 3 visits. You check the blood pressure and let's see what it is, right? We could go to the next slide. All right. So this slide has a lot of information on it. All right. This is based on some guidelines. Everything is really based on a lot of guidelines. So this would have been 2020 guidelines for the International Society for Hypertension. And I'll pay a little concern to 130, 139 as well. That's like high normal, right? You need to watch things there. But the grade 1, the 140 to the 159, and the bottom number 90 to 99, right? Pay attention when you have those kind of values, right? So on the repeated visits, you're having those values. I'll be a bit concerned, okay? Grade 2, greater than or equal to 160. That's the systolic, and the diastolic greater than or equal to 100. I'll be very concerned about that as well, okay? How it is you manage the grade 1. I'll just look at it one time because we're on that. All right, so the grade 1, you don't just rush into meds or tablets. You do lifestyle changes, all right? And, you know, you let them change their eating, probably introduce some exercise, decrease the amount of salt in the diet, you know, less fries, all those different things. So we're focusing on lifestyle. All right, the only time that you would add tablets would be when there is evidence of what we call disease. So you have cardiovascular disease, that's CVD, the kidneys having some injury. That is when you will start to introduce medication. All right? And then you have the grade 2. The grade 2 you would treat. Yeah? With both lifestyle. Everything is lifestyle as well. Lifestyle and meds. The next slide. Okay. This here basically highlights some of the different things that we may be confronted with. So white coat. Everybody does, oh my gosh. Plenty of people have white coat. So you all know what white coat hypertension is. You go by the doctor. Right? Not that the doctor have on a white coat, Is that you go by the doctor and the night before you anxious. Oh gosh. I don't know. Oh gosh. I don't know what the doctor gonna tell me. Oh my gosh. Your heart racing, palpitations, everything. So when you go by the doctor now, oh my gosh. You're rich. But your heart's still racing. You're anxious. So obviously when they take the blood pressure, it's high. But you take your blood pressure home and it's normal. When I say normal, it's not that high. You understand? When you compare it with, so that is white coat. So that simply means in the office, the blood pressure raised, and at home, it's fairly okay. All right? Good? And then we have the masked hypertension. That is when the one in the office is normal and the one home is high. That's a problem. That is a problem, right? The one in the office, normal, and the one at home, high. And there are different ways to actually diagnose. And that is when you start doing, remember we said that you could take your blood pressure monitor in the clinic and outside the clinic, right? So you do comparisons to see which one it is. Is it that you have masked or the white coat hypertension? Yeah? The next slide. All right. This is explaining the same thing. The same thing, but the mask and the white coat hypertension. All right. The same thing. Masks and you have sustained, you have masks, and you have, right, taking the blood pressure. This is important, how you actually take. So lots of people have blood pressure kits at home. How you take it is so important. The size of the cuff is so important because you can get erroneous readings. All right. So if it is you, probably you're sitting down, but you're probably your leg, or you're crossing your leg. You know, it can affect the values. All right. So you're relaxed. You sit upright, erect. Your feet firmly planted. You have the right size cuff. There's the width and the length of the cuff. There are certain measurements that's really important. You know, if that, sometimes, even like if you go to in the hospital, they're using the wrong cuff. So you know where again? Wrong reading. So you know where you have to ask them, and then we have the numbers. We have the top number and the bottom number. All right. So the top number is the systolic number, right? That's the systolic blood pressure. And the bottom number is the diastolic. So what the top number means, when the heart contracts, the pressure in the blood vessel at that time, right? Which would obviously be high. So you could never have a diastolic number that almost super as high as the systolic. That's not making sense. All right, and the diastolic would be the pressure in the blood vessel when the heart is in a relaxed state. Yeah? So there are two measurements, top, which is systolic, and bottom, diastolic. Right cuff must be used, else you would get a wrong reading. Okay, the next slide. All right, so this year, so anybody who has hypertension, you must be managed a particular way, all right? Because one thing we know is that hypertension increases your, at least uncontrolled, increases your cardiovascular risk, all right? So what do we do we always assess for cardiovascular risk. And the doctors will do or should do some sort of calculation for that. Then you also look for evidence of damage to other organs, all right? Damage to other organs. And also sometimes people could have another cause that we call a secondary cause of hypertension. All right, so not all hypertension is because of salt and you're getting older. All right, we have secondary causes. So there's a very comprehensive assessment that should be done for patients with or persons with high blood pressure. One of them is obviously you do bloods. All right, so we do the RFT there. If you notice CBC and RFT, the RFT is what we call for the kidneys, the renal function test. Important things there would be the creatinine. So you go to the doctor says, I'm going to do a renal function test or check for the kidneys. You're interested in my creatinine and what my potassium is. I'm doing my lipid profile because that's part of my cardiovascular risk assessment. All right? I'm doing also my fasting blood sugar. I'm doing my urine because in the urine, the kidneys could be damaged and there could be a leakage of protein and blood. So your urine, and you know that when you go to accident and emergency or you just go to the doctor's office, that's one of the cheapest things to do. Yeah? You pass urine in a cup, you have your stick, and you dip it in. Yeah? And they're looking for different things, whether it's protein, whether it is blood. Yeah? All right? Then we have our ECG. Everybody familiar with an ECG? Okay? So the ECG gives you an idea of what's going on in the heart, the electrical activity, and it gives you some lovely changes if you have high blood pressure and it's uncontrolled. You see some things on it, some changes, right? The chest x-ray, you could also identify changes on the chest x-ray. The heart size could be super big, all right? The fundoscopy is looking at the eyes. Remember we saw with the eyes before with the diabetes, that was doing the fundoscopy. So you also look in the eyes because the retina, which is at the back of the eyes, could be damaged with high blood pressure, yeah? And then, well, we have other tests that could be done. But those are the key things. I need my kidney function. I need my fasting blood sugar. I need to check my cholesterol. I need to pee in a cup to check my protein. I need to do my ECG, do my chest x-ray, and also check my eyes. Why? Because all those things, my kidneys could be damaged, my heart could be damaged, my eyes could be damaged. Next slide. All right, so this just showing the urine dipstick, right? This is a very inexpensive way to check injury to the kidneys and other things. This is the ECG on that side there, some changes that could happen, right? If the blood pressure is really uncontrolled and high, consistently high. The next slide. So this just showing damage to different structures, right? This on that side there is a chest x-ray where we see in the heart is a bit, well, I seen that it is a bit big. You all may find it's normal, but it looks big. All right. So that we can detect certain things on there as well. And then this side here, sometimes if you leak protein in the urine, so when you do your dipstick and you find that there's a lot of protein in it, because it is like what we call a qualitative test. So you might see, they might write on the form 2+ blood, 2+ protein, that kind of a thing, right? So you can go and do further testing, which gives you more of a quantitative test of how much protein leaks in the urine, right? So this is this one on this side here. The next slide. All right, and again the eyes always getting some injury. All right, so this is showing some changes that happen in the eyes, bleeding, a lot of different changes, kind of similar to the diabetes. Sometimes the disc in the eye could become swollen as well. That's some serious thing. You have to refer to the eye doctor. The next slide. All right, these are some targets that we have for when we're looking to control the blood pressure. All right, so we have over 65 and over. You aim for less than 140 over 90. Again, all these things are individualized, you know. So if the person can't really take too much a drop, you keep it probably at a 140 and 90, right? So those are some of the targets that you want. You don't want numbers like 160 over 100. We don't want those kind of values. Next slide. All right. This slide looks at some of the risk factors, which are very similar to that of diabetes, advanced age, again, family, gender, obesity, diet. So you realize that a lot of these risk factors are very, what we call modifiable. You could change. You could become physically active. You could change your diet. You could lose weight. Well, you could do things to reduce your stress. You could stop smoking if you want to, right? And then we have some secondary stuff. So there's this thing that we call primary hypertension, meaning that primary meaning unknown. We don't know. They do all the research, but we don't know why, okay? The majority of high blood pressure is what we call essential or primary hypertension. And we have a very small portion, 5%, where there is some known cause, all right? And that's called secondary hypertension. And some people do have secondary hypertension, yeah? All right. Okay, so these are the complications, right? We kind of touched on it when we went through the ECG and the different things, the cardiovascular assessment. All right, so these are the things that could happen. Your heart could fail, right? We have lots of people with heart failure in our nation, heart failure. You could have cerebrovascular disease, that's the stroke, all right? Cerebrovascular. You have the retinopathy, again, that's the eyes, and then the chronic kidney disease, all right? The next slide. All right, so this is just showing the heart. I don't know if you're all seeing some changes in the one that has hypertension. All right, so we have here the top and the bottom. Well, no, those are two bottom chambers there. All right, the LV. You all seen the LV there? LV, which is the left ventricle, and the normal heart. You all seen any difference? What you all seen there? What is popping out at you? Right. Which one is what bigger? What are you talking bigger? The muscle? The muscle. Right. So all that chunk of that looks like meat, right? That's the muscle. That's the heart muscle. So if you notice the one with the hypertension, the muscle is thicker, eh? Why do you think it get thick? Right. That is the concept. Very good. So all you're working out the heart muscle, all you're wicked. Yes, so the pressure high. The heart muscle saying, oh gosh, I have to work against this, pump against this. Oh my gosh. I'm pumping against this pressure. Ooh, I'm pumping, and every time you ain't taking your pills, you know, you ain't even checking your blood pressure. Because, oh gosh, you ain't checking it. So a month pass, pressure, 2 months pass, 1 year pass, 4 years pass, and you're not checking it, but you're saying, you're not doing it. And then eventually what happens is that this muscle is working against a pressure. So say your pressures are, just say for example, it is 200 over 100. Imagine every day my heart is pumping against this pressure, oh gosh, 200 over 100, 200 over 100. Morning time, 180 over 100. Evening time, 200 over 100. This is what is going to happen. So the muscle, again, we call it in our nice terminology, hypertrophy. Hyper, compared to the dementia brain that undergoes atrophy. So this hypertrophy of the muscle, which is not good at all. You know, when you get big muscle, it's good, right? Yeah, but when the heart muscle get big, it is not good. It is not good at all. All right, good? So structurally, this is what is going to happen. And this eventually ends up in heart failure if it is not addressed early. All right? So next one. So that is what we call hypertensive heart disease. This is another complication of uncontrolled blood pressure. Again, remember the plaque that we saw in the leg? This is the whole concept that we call atherosclerosis, which is not a good thing at all, right? Because what is happening is that in the brain, in the blood vessels of the heart, in the leg, fat is starting to accumulate, and there's a nice process that happens, but it happens gradually over years. All right, until the blood vessel, if you notice, gets narrowed. All right, so all this fat on this side is a real interesting process. Fat starts to accumulate under a nice fibrous cap. All right, it's hiding there. But then what eventually happens is that any trauma, anything to disrupt that plaque will literally expose the hidden fat and cause a clot to form, blocking the blood vessel, and that is how people get strokes and heart attack, right? Because that fat that was coated by that fibrous cap ruptures and exposes what is underneath, and the fat underneath is what we call, it is thrombogenic, so it literally triggers a clot to form, and that clot blocks the blood vessels, all right? So this is the process of atherosclerosis, which again is something that takes place over time. All right, this again showing the same thing. We can't see the things, but we have fatty, you have some inflammatory cells, everything, there's some inflammatory component to it. You have some fatty, the fat streak that initially starts, but it's fats, right? Then you have the plaque that accumulates, or the fat forming the plaque, and then it becomes covered, that fibroatheroma, that's the fibrous thing covering it. And then the complication is now when it ruptures and it gives you your stroke and your heart attacks. The next slide. Right, so that's it for hypertension. Any questions? You look you look super exhausted. Oh gosh, yes.
Is the low blood pressure just as dangerous as the high?
Okay, it depends on what you mean by low. It depends. So if it is, okay, so there's something called hypotension, all right, which occurs on the background of some sort of acute problem. So say, for example, my blood pressure is, my normal blood pressure, that is, right, is 120 over 78, right? And then for some reason, my blood pressure goes to 70 over 50. That's a big drop, end. Something wrong. So something wrong. So that's bad too, end. Yeah, because that could cause problems. But you have to find out why. You have to find out the why. It could be probably you're taking too much tablets. You understand? And it dropping the pressure. That could be a reason. Or it could be that you're sick. Yeah, that you're sick. You probably have a serious infection and it dropping the pressure. Probably have a clot in your lung. You probably have a heart attack and you didn't know. Plenty things.
Yeah, but it is bad. But obviously you have to compare, because some people have naturally, like if they're small, they may have lowish blood pressures, like a 98 over a 60 something. You understand?
Right.
Yeah? But that's normal for them. Yeah. Everybody good? Your brain over soaked, soggy. Oh gosh.
I'm just thinking, if a patient
Mm-hmm.
lies down and the pressure is taken,
Yes.
are you going to get a proper reading?
I didn't hear the full question.
Lying down and
Yeah.
having your pressure taken.
Right,
Yeah.
right. So lying down.
Yeah.
Right. So
Opposed
you
to
mean if that person seated up? The thing is that's okay. The that you're taking the blood pressure on. I think it's supposed to be in line with the chamber. Yeah. So once that is the case, then you're okay. You understand? So
This way,
Yeah,
sitting. This way sitting.
yeah.
Your arm's supposed to be.
Yeah, so when you're seated, you know you will have like a surface. Your arm won't be down like that. No, it's supposed to be upright like this, so that it's in line with the chamber of the heart. So even when you're lying down, it's a similar concept. Your arm not supposed to be down like that and taking the blood pressure. Yeah? Yeah, either or. Either or. Yeah, either or. The cough. The cough. Our nurses will demonstrate. Our nurses. Yeah, they have a right way. There's a right way. There's a marker on the arm, on the cuff. There's a marker, so you know it's supposed to be aligned with right here. There's an artery right here. So it's supposed to be aligned, that marker, with the artery. It's called the brachial artery. So it's supposed to be aligned there. Yeah? Right? So even if you're doing it with the modern machines that you have, there's still that marker. So you know exactly where to align the arm, where to align it. Right?
Yeah. Question.
Mm-hmm.
When you come out of a sleep,
Mm-hmm.
is it a wise thing to just jump out of your bed, or
Mm-hmm.
you take your time and get up? Because I've seen, I told my sons and them,
Mm-hmm.
don't just jump out of your sleep like that,
Mm-hmm.
because it's not good for your system
Right.
to just jump out of your sleep and get up
Right.
and run to the bathroom. Now, some young people do a lot of wrong things, so they tend to find you get up and you run to the bathroom, or you get up too quick and the
Right.
blood rushes to your brain.
Right.
So is it wise, or you take your time
Right.
and get up from
Right.
your sleep,
Right.
or you stretch?
I guess you could do that. I mean, we're so busy these days. Who taking the time to sit down?
Yeah, but it's not a good
Oh
thing.
gosh. Well, the thing is, I mean, there are certain conditions. Let me see if I will answer the question from a medical point of view, right? So there are certain conditions when you get up from a lying position and you stand up, suddenly you could feel dizzy, right? Good. So with such conditions, you have to get up, sit down for a while, and then you stand up. Right? Good. So I know that is important for certain conditions, because what happens, there's this condition called postural hypotension. Postural meaning you change position. You change your posture from like a lying or sitting position to standing, and the blood pressure drops on standing. So when you do that, immediately the blood pressure drops. So there's decreased blood supply going to the brain. So you could become lightheaded, you could faint, you understand? You could collapse. All right. So in that context, it would be advised that's that progressive thing. Yeah?
My question is, does a low blood count, I know, because ladies specifically would suffer from low blood count. So does a low blood count affect your blood pressure or vice versa?
Okay, that's a good question. Acutely, if it happens acutely, meaning if it is you get a gunshot wound now and you start to bleed, you're bleeding acutely, your pressure is going to drop. But if you are bleeding over, like, this is something chronic, your blood loss happening over years, your blood pressure is not going to drop. Because remember, when you lose blood, suddenly the response by the heart is you're losing blood. Your blood pressure is dropping. The response by the heart is that it's going to work a little more, increase the heart rate to bring up the blood pressure. But the scenario has to be an acute scenario. You're losing blood. So say, for example, another example is you, all of a sudden, you're starting to pass black stool or blood through the rectum. Check your blood pressure. You pass a lot of blood, check your blood pressure, because it's an acute thing, an acute loss. So with the acute loss, the blood pressure is going to drop. Yeah? With the acute blood loss. But if you have something chronic happening, like a chronic anemia, your blood pressure is not going to drop. You understand?
So chronic anemia would be related to what?
Anything. The concept is this: chronic versus acute. Acute meaning suddenly. Yeah.
Right.
Like, okay, one of the easiest thing is somebody get a gunshot wound.
Right.
They get a gunshot wound and they're bleeding profusely. The first thing they're going to check is their blood pressure, their vital signs.
Right.
They see the vital signs 70/40. What they're going to do? Put up fluids. They're going to put fluids up because that's an acute blood loss. As opposed to, I have probably my periods having a lot of bleeding, but that's only happening once every month. And my blood count probably is 9, and my blood pressure is not going to drop because that's something chronic and my body's compensating all the time, pushing out red blood cells. It's not going to affect my blood pressure.
Okay.
But the acute loss and a significant loss, because they have, the body could go into what we call shock, but it has to be the different increments. You lose a certain volume, it goes into something, it loses a certain volume, but it has to happen acutely to have an impact on the blood pressure.
Right. So on my follow-up question would be, so you mentioned the blood count being like a 9. I
Yes.
think the regular is supposed to be
12.
50.
For females, 12.
Right. So with a low blood count, you would sometimes have that lightheaded feeling.
And that's correct. Yes, that's correct. That's when you become symptomatic.
And what is, so it just means that
but your blood pressure would not feel it.
be,
Your blood pressure wouldn't feel it.
okay.
Right? Only if you have a significant acute loss, your blood pressure is going to feel it.
Okay.
Right? Yeah? No, everybody good with questions so far? All right. It's now 7:47. The other thing was strokes. Do you want me to do this, or you want me to? Let's do the strokes. Okay, sure. So strokes. Everybody okay with everything so far? Everybody understanding? Everybody like it? Everybody have to say yes, because if all they don't say yes, everybody like it?
Oh my. So strokes. Strokes, right? So strokes, we have strokes that could happen in the old and the young. Some of the objectives, hypertension as the leading cause of stroke, smoking, because plenty people smoke, smoking, cigarette and stroke. All right, so we could go to the next slide. So we know that young people get strokes, and? All right, so y'all seen, this is supposed to be the brain here. Y'all seen, well, anything looking strange in the brains? Anything looking strange in either of these brains there? They have some arrows pointing to something. So it's looking, this one here, what do you think this one is? You could have bleeds or you could have infarcts. Which one is this one? This one here? No, this one? A bleed or infarct? Right, so this is an infarct and this one is a? Right, that's a bleed. Yeah? All you find are looking big? Looking big. Yeah, that's some things that you see, you know. You see some bleeds that, and I don't know if all you're looking at the brain, how it is there. You notice that there's a midline, a middle, right. Or you notice how the bleed have it white, but it have an area around it, right. That is what we call edema. So edema, again, this is the response of the body to any injury. Wherever it is, you could have a bleed, whatever. It's in the tissue is injured. So all of your inflammatory mediators come to this site and edema results. Is edema good? Yeah. In the brain, is it good? No. All right, because if you notice what is happening, you'll notice that part of the brain push to the next side. Aha. So I just given all you a picture. Your blood pressure is super high. Just think about it, super high. You're not taking your pills, 200 over 100, yeah? So you end up with weakness to one side, you can't talk, they do a scan of the head, they see this here, and part of the brain is being pushed on that side. That's not a good sign, because what could happen, because the brain cannot tolerate all of this swelling, that is what is happening there. It's edema brings swelling. It pushes brain tissue to the opposite side. The mass effect, that's what we call it. The mass effect is the push. So when it pushes, it will squeeze. If you notice, that little piece up there is being squeezed. You notice that, right? So that is what is happening with the brain. On this side here, this is, it looks like an infarction here. It's also huge. Look at how much of the brain mass is involved here. And this could also, you could have edema around that, and it could also push the brain tissue. But you tend to have more of the mass effect with a bleed. Yeah? More of the mass effect. And bleeds, by the way, the prognosis of bleeds tends not to be good. So that is why it's always encouraged, keep your blood pressure well controlled, because suddenly you could have a bleed and you can die. All right? The next slide. All right. So again, this is just some statistics. I mean, strokes, very, very common. We see 3/4 of all strokes occur in those who are 65 and over, compared to young adults. And the young adults, we have the bracket here, 20 to 44, 1/4. But that's still significant for young people. And then this, the table there is actually showing, this here has to do with, I think this one was young people, where they did a little No, this is just with strokes in general. All right, and the incidence and prevalence, which is pretty significant. And we know that with strokes come disability. Yeah, disability comes with strokes. It's a package. All right. The next slide, and obviously the mortality. Yeah. All right. So we have different strokes, which we highlighted. The most common stroke is the one with the decreased blood supply that we call the ischemic stroke. right, makes up the big chunk of all strokes, 62%. The ones that are bleeds, 27 roughly. And then we have another type of bleed, the one below there, the subarachnoid. All that comes under bleeds. All right. The leading problem with strokes is poorly controlled blood pressure. All right. The next slide. All right. So this is ischemic strokes in the young adult, which is age 20 to 44. And these are just some stats from US, Europe, India. And it's kind of high there. 28 in 2015, that's in the US. 28, the incidence, that's new cases. 28 per 100,000 compared to 1993, 17. All right? And similarly with Europe, there was a trend of an increase. In India, significant. From 4, the incidence of 4 per 100,000 to 41 per 100,000. All right, so it means that, young people have to take care of themselves as well. The next slide. All right. So basically, this explaining the same thing as the data that we saw. This is just in a graphical presentation, right? The data is the same. Right? So the risk factors, again, everything seems to have similar risk factors. With elderly people, some of the things that they will tend to have, low down on the list there's a heart condition called atrial fibrillation that goes hand in hand with the elderly population, all right? And that's a big risk factor for stroke, right? Atrial fibrillation, physical inactivity, the diabetes, the hypertension. Again, it's a package. In the young people, you always ask about substance abuse, all right? Cocaine, could cause strokes in the young population. Right, we have some non-modifiable ones, right? Obviously, you can't, let me see here, age, you can't change that. Hereditary, race, you can't change that. Sex, male or female, prior stroke. So those are some non-modifiable compared to the modifiable. So, you could always reverse things, or I should say prevent things. That's the beautiful thing about health. There's prevention, right? So we could change the modifiable things, right? Change. So if there's a strong family history, you check your blood sugar, you check your blood pressure, you invest in a machine, you go to the doctor, you don't smoke, you check your cholesterol, you become a little active, you understand? So you can modify things, yeah? The next slide. Yeah. You on the mic?
The sign that had the male and the female, I saw a greater than sign by the male. Does that mean that males are more prone to strokes than females?
Yes. Don't ask me why. Yeah. I'm not sure why though.
Stress.
Stress. Oh my. Stress. All right. So this year, the causes of stroke in the young is very variable, and these are lots of the causes here. You don't really see them in the older population. So if a young person has a stroke, we tend to really investigate them properly. We ask a lot of questions. Because in the older people, we know that over years, they probably have diabetes, high blood pressure, they have plaque in the vessels, So that's so common, right? If you notice up there, arteriosclerosis only accounts for 10%. There's a young person. A young person is supposed to have a lot of plaque in the blood vessel. You understand? Unless they're eating KFC probably from a child or something, but they're not supposed to have a set of plaque. All right? So that here is a component if they have risk factors like smoking, high blood pressure and stuff, right? But you have to look at other causes. You have to look at the heart. The heart could be a problem, right? So you have to do things like, I don't know if you all ever heard of echocardiogram. And echo, you look at the heart, you look at the structure of the heart. You know, some people could be born with little hole in their heart and thing, right? So you check what's going on at the level of the heart. That's super important to investigate strokes in the young. All right, we have, so that's 15. If you notice, that's a big chunk. 15 to 35% of persons who are young, between the ages of 20 to 44, you look for something in the heart. You understand? So if a young person comes with a stroke, you don't just say, well, okay, probably it's arteriosclerosis. No, right? You look for something in the heart. Then you have other things. They're underneath the cardioembolic. That simply means heart. Cardioembolic means something is going from the heart and going to the blood vessels. Embolic, right? And then we have underneath the non-arteriosclerotic, meaning you don't have fat, but there's something wrong with the blood vessels. Some young adults could have what we call a dissection of one of the vessels that's providing blood to the brain. What that means is that there's a tear in it, all right, that happens, but there's normally like a preceding factor. So say like they're involved in a traumatic, like a motor vehicle accident, and there's a tear that goes there, and it decreases the blood supply to the brain, and they get a stroke. All right, good. So that's one thing there. Then they have what we call hematological secondary to blood problems. That's 10%. Females, if you see a female with stroke, you always ask them, you're using oral contraceptive pills, right? Because that could cause clots to form within the blood vessels. Yeah? All right? And then we have what we call inflammatory conditions, infections. All right? So it's different compared to all the causes, totally different compared to the seniors, the elderly, right? Which would be like you're over 65, right? So the investigations would gear towards or point towards looking at these things. So they must do an echocardiogram. They must do other bloods, right? They must screen for if they have what we call inflammatory things, autoimmune disease. They must ask specific questions. Females tend to have autoimmune disease. Females have reproductive age. You ask a family history of autoimmune disease because the presentation or the causes very, very different compared to the elderly. The next slide. All right. Again, stroke in the young. They can have, in the young who have bleeds. The first slide was ischemic strokes. This one is bleeds, right? At least the top part. The top part. So if somebody, a young person, come with a bleed in their brain, all right, we have to investigate more. We have to find out a drug history, all right? Cocaine use could cause bleeds. We have to scan the brain. So we're doing extra investigation by looking at the blood vessels. We call that an angiogram. And we look to see if there are aneurysms or malformations of blood vessels. Yeah? Right? So that's if you have bleeds. Which again, you wouldn't really do for a senior person. The next slide. All right, so this just shows the blood vessels and the aneurysms. You notice that little sackish thing, the saccular aneurysm, the blood vessel not normal. All right, so it can rupture easily. And then on that side, it's showing you what we call the AVMs, which is these abnormal communication between the arteries and the veins. So the high blood pressure in the artery could literally rupture the veins, right? Good. So if you notice, this here, the middle one without that problem, and then the extreme, the one on the extreme end there,
shows the problem. And this is for young people. So you have to do that additional investigation apart from a CT scan of the brain, and you have to look at the blood vessels, the integrity to see if you have aneurysms or these abnormal vessels called AVMs. All right, so this is smoking and stroke. I think probably almost everybody smokes. Oh my gosh. Oh, I think almost everybody smokes. So, you know, smoking contributes to so many different things. All right. So heavy smokers smoking about a pack, because 20 cigarettes in a pack, right? Smoking about a pack a day. Right, and there's an association with stroke. They said here, studies show that 2 to 4-fold increase in stroke among smokers compared with non-smokers or even persons who have quit for more than 20 years. Smoking is really a problem, eh? Smoking is a big problem. And I mean, it's a stress reliever, but it's a big problem. You know, it's an addictive problem. The next slide. All right, and what smoking does, we know the relationship between that and arteriosclerosis. Arteriosclerosis, all right, yeah, so it's also, so it could cause ischemic strokes because of the arteriosclerosis, right, and also there's some relationship between smoking and hemorrhagic, so it seems as if it could cause both ischemic and hemorrhagic strokes. Right, the next slide. All right, so that's it for strokes. Yeah, so that's it for strokes. Yes. All right. Okay. Yeah, this is it. No, this is the next section, but we have finished 3 so far. 4 actually: dementia, hypertension, diabetes, and strokes. Yeah? Right? I think everybody tired. Ooh. It's a lot of information. Yes, sure.
Stressed on smoking and the effects of smoking and what it does. And I don't know if it just pertains to nicotine. Is there a different result or effect with people who smoke marijuana, or is it the same thing?
With regards to strokes?
Yeah.
Strokes. I know that I haven't done research on that, but I know that marijuana use could affect the heart and cause heart attacks. Now, I don't know if it causes arteriosclerosis. That I don't know. All right? But I know that it could have an effect, because even when we see patients, and again, almost everybody use marijuana. No, serious. Everybody. No, serious. No Rasta using marijuana. Male and female using. No, serious. So how it contributes to cardiovascular disease, I am not sure. I'm not sure how it does. Like smoking would cause the arteriosclerosis. I'm not sure if it's the same mechanism, if it's the same thing that happens. Yeah?
I think smoking marijuana is worse, because marijuana now in Trinidad, coming from abroad, have embalmed fluid in it.
Right.
So I think it's worse.
It's worse.
Yeah. That's embalmed, bring it across the water.
Right. Anybody else? Everybody full? Oh gosh. All right. Well, thanks everybody. Yeah. You're good. You're good.
Come on, we could do better than that. If you're clapping, clap right. Wow. That was plenty. It was. You heard it too? Amen. But Doc, we really appreciate the information that we receive here tonight. And as I said before, we have prayed and really just don't know the information. We don't have the knowledge of certain things that we're really praying for. And we thank God that this came to us today. And we have to live right. We have to treat our bodies right. Amen? Now, I know it is a little way after 8, but we wouldn't get the doc every day. And I think that we would really like to do a second part on, we'll speak about it so that we could finish. Because it is a lot. It is really, really a lot. And I feel we may have to do that. I know.
My computer just putting together this presentation and is like, my God, this is an examination you're giving me. No, I was asleep. I didn't get sleep.
It didn't get easy. But she delivered, Yeah, let's thank God for that. Right? I don't want to really leave out the area of the sugar and the blood testing. We could still do that, right? Who want to remain to get their sugar tested, you could do so. Who want to leave thereafter, you certainly can. But I want to really thank God for what is done. I think since I am in this ministry here, I think this is the first time that we had this kind of interaction in the area of health and stuff, right? And I thank God. And wow, so God is good, amen? Minister, can just get me something that Mark, Dr. RAELENE, and I know that you have your colleagues here. Yeah, that one. Yeah, I don't know. Yeah, it's both. I don't know if she like pink, but it doesn't matter. It's not the color. Wow. Well, we'll get to that. Yeah. So, come. Yes, come. Come and just present this to Dr. RAELENE, thanking her for the work. Well done. Huh? Yeah, both of them.
So, Dr. RAELENE, on behalf of leadership and VKM and all of us here, we really appreciate the information that we got overloaded, but this was really good, and we thank you for your time and your effort, and we appreciate it. Thank you so much. You're welcome. Enjoy.
Thank you.
Thank you. And well, Nurse Wilson is here, right? Which one is? Well, she have to assist you with the sugar testing and stuff. So you all may not have heard, but this is one of our colleagues. So Nurse Wilson, we want to really thank you. And let me ask Minister Ricken to just come and present this quickly to. It's Rhea, right? Nurse Rhea Wilson.
Okay, Ms. Wilson, on behalf of Valley Kingdom Ministries, we want to thank you for showing up, and you're getting paid before you work. But that's how we do it at VKM, right? So we just want to present this to you, and thank you for being here, and we thank you for your assistance in the room next door.
And also Nurse, is it Ayana? Ayana Joseph. Let's, another one that came, and it's your birthday, right? So let's do this right. Let's do this right. Let's do this right. We ain't going and sing. We don't have time for that, but I want to bless you. Right? Is that okay? Okay, come here. Father, just stretch your hand in this direction. Father, we thank you for Ayana. We bless her today as she celebrates her orbital year. And so, God, we declare the purposes of God that as she lives each year, she shall walk in the purpose and the promises of God for her life. I speak health, I speak strength, prosperity in God. Her soul prosper, and so shall her body. And so, Father, we thank you for her. In Jesus Christ's name, amen. Elder Morne, come and just present this. All right, so you want to sit?
Okay. First of all, I want to wish you a very, very happy birthday. And I want to thank God for me being part of that, celebrating with you today. Anyhow, I want to present this token of our love and appreciation to you, and for being here and being able to share with us in whatever way you're going to do. And this is coming from the leadership of Body Kingdom Ministry and its members as well. So thank you very, very much.
Wow. Amen. I mean, it was plenty. I'm leaving it in my head. Yes. Amen. So let's stand, and as I said, that we still have that segment open. If you have to leave, it's all right. But if you want to get it's sugar and pressure, right? It's free, and we have the aid here. So, Father, we thank you for tonight, the information. We thank you for Dr. RAELENE, who took that time and pulled that information together for us. And so, Father, we bless her. We bless her family. We bless the VKM family, all those that are online. We thank you, dear God, for those who tuned in. But most of all, Father, we thank you for you being God and in charge of our body. Because we know that at times we have abused what you have given us, dear Father, and sometimes it needs more than the medication. Sometimes it needs a miracle. And so, Father, we thank you for this information so it wouldn't have to reach to asking for a miracle, but we'll take care of that which you have given us. And so we bless you. May the persons who even don't have transport, they reach to their destiny safely. So, Father, I thank you and I give you praise and I give you honor for tonight. In Jesus Christ's name, amen and amen. So,